speaker, and it's an absolute honor and privilege to welcome Dr. Michelle Kittleson, actually back to Yale to give cardiovascular grand rounds. Dr. Kittleson graduated from Harvard College with a degree in biochemical sciences. She came here to Yale, where she graduated from the medical school in 1999 and proceeded to an internal medicine residency at the Brigham and Women's Hospital. Following that, she did cardiovascular Hopkins with a PhD in clinical investigation at the Bloomberg School of Public Health. She's currently an advanced heart failure and transplant cardiologist at Cedars-Sinai Smith Heart Institute, where she's a professor of medicine, the director of the postgraduate medical education in heart failure and transplantation, and director of heart failure research. Dr. Kittleson's research interests are quite varied, but include the triage of heart failure patients to advanced therapies, and as related to her talk today, antibody sensitization in heart transplantation. She's also done some recent work in cardiac amyloidosis. She's a very prolific author of several book chapters and numerous articles in peer-reviewed journals. She's been the recipient of numerous honors and awards for clinical work, for her research and teaching, including the Samuel Levine Young Clinical Investigator Award from the AHA and Clinical Faculty Teaching Award from the UCLA Department of Medicine. Dr. Kittleson also has a big interest in medical writing and narratives, which I found a lot of your articles and poems very fascinating. She's written articles, poetry, opinion pieces in JAMA, New England Journal, and actually has what I think is one of the most compelling medical Twitter handles. She's at mkittlesonmd, and if you haven't seen the hashtag Kittleson Rules, I think you should check that out. It's both literal and figurative, and some very helpful practical tips, not just for new interns, but for all of us. She really is very eloquent in her writing about the observations and nuances in the practice of medicine and in the care of patients, and very pithy in her advice. Of note, and I thought this was great, Dr. Kittleson's parents, Drs. Edward and Margaret Pinto, are long-term staff at Bridgeport Hospital, and I believe we have some colleagues who are joining grand rounds today from Bridgeport Hospital, and I'm sure they're very proud of you and of all your accomplishments. So Dr. Kittleson, it's an absolute pleasure and honor to welcome you back home to Yale to give cardiovascular grand rounds.
Awesome. Well, thank you so much. That was the most lovely introduction. And yes, I'm so delighted to be virtually back at Yale. And fast fact, I was actually born at Bridgeport Hospital. So pretty cool how all this comes full circle. So we're going to talk about the approach to antibodies in heart transplantation. Let's see here. Let me advance my slides. 1 second, please. Oh. Perfect. I will discuss the off-label use and or investigational use of everolimus, Bortezomib, Eculizumab, and Tocilizumab, but I have no relationships to disclose. Now, because everything in medicine is more exciting when we talk about a patient, let's begin with a case. A 35-year-old woman, 4 months status post-transplant. She's on standard triple drug immunosuppression with prednisone, tacrolimus, and MMF. She presents to an outside hospital emergency department with nausea, vomiting, abdominal pain, and fatigue. She's prescribed ciprofloxacin for gastroenteritis and sent home, but presents to the ED the next day with worsening symptoms. What do you advise the ED staff when they call? Now, I imagine this is not an uncommon situation at Yale, like it is at Cedars, where many of the patients we transplant don't live in our local area. So we're often fielding phone calls from outside emergency departments, triaging patients over the phone. So what are our options? We could recommend a colonoscopy, pan culture, begin IV antibiotics, check an echocardiogram, or discharge the patient on pantoprazole. Well, I think we'll all agree that choice D is not the right answer. I have a rule in medicine that if a patient presents twice with the same symptom, the second presentation deserves a more thorough evaluation. So you're not going to just send her out with a Band-Aid like pantoprazole, which she's probably on anyway because she's on steroids. I have another rule that any patient post-transplant who presents to the ER within the first year of transplant has rejection until proven otherwise. So you'll check an echocardiogram. And in fact, the echocardiogram demonstrates an EF of 20%. Her symptoms are likely coming from hepatic congestion. She's transferred to your hospital where her heart rate is 130, blood pressure 80/60. She has multiple runs of non-sustained VT. JVP is estimated at 16, S3 gallop, cool extremities. Dopamine is started, biopsies performed, and on the biopsy, the right heart catheterization shows RA 20, PA 45/30, wedge 30, cardiac index 1.3. So the very picture of cardiogenic shock. So how do you manage this patient? Well, you could perform an emergent coronary angiogram, consider a balloon pump if she deteriorates, initiate anti-rejection therapy, administer IV heparin, administer IV diuretics, start IV heparin. Well, I would argue that the emergent coronary angiogram is likely not indicated. She's only 4 months post-transplant, so the chance that she has developed allograft vasculopathy at this accelerated rate to cause her presentation is very unlikely. But all of these other options are in fact reasonable. IV heparin, in fact, because autopsy series of patients who die of acute rejection have shown thrombus in the microvasculature of the coronary arteries. So we put it all together. When we think about the treatment for rejection, it depends on not just what the biopsy shows, but on what the patient looks like. So if a patient is asymptomatic, we may simply target higher levels of their CNI, the calcineurin inhibitor, give them an oral steroid bolus and taper, and switch their mycophenolate, MMF, to a proliferation signal inhibitor, or PSI. If they have antibody-mediated rejection and it's asymptomatic, it's a little trickier, contentious, but oftentimes these patients will get an oral steroid bolus and taper. Once they have a reduced EF, the treatment gets more intensive, IV steroids, maybe some IVIG. When they are in heart failure or shock, we treat first and think later. Look at the biopsy later. We don't wait for the biopsy to come back. We throw the kitchen sink at them, and that would include IV pulse steroids, cytolytic therapy with ATG, anti-thymocyte globulin, which will target T cells, B cells, plasma cells, plasmapheresis to remove preformed cytotoxic antibodies given before the ATG, so it doesn't ferrese the ATG away, IVIG, the polyclonal antibody preparation that blocks antibody function, inotropic support, IV heparin, and even to go so far as temporary mechanical support with a balloon pump all the way to ECMO as a bridge to recovery. So for this patient, her hemodynamics deteriorate with recurrent VT, a balloon pump is placed, dobutamine and furosemide are started, her VT gets better, now her RA is 10, PA of 30/20, wedge of 20, index of 2.5. You have bought her some time and start empiric therapy with methylprednisolone, ATG, plasmapheresis, IV heparin, and the next day, the biopsy shows the classic findings of antibody-mediated rejection. Now, I have a confession to make. My mother, as you heard, is actually a pathologist, but understanding of interpretation of slides is not an inherited trait. Therefore, I require the arrows to tell me what's going on. So on the H&E staining, we see intravascular lymphocytes shown by the arrows, and then we do immunostains. So CD68 stains for macrophages, which are prominent in the pathophysiology of antibody-mediated rejection. CD34 stains for endothelial cells, which demonstrates that the macrophages are intravascular. CD3 stains for T cells, not prominent in antibody-mediated rejection, a B cell process, and there's complement in the capillaries. When we think about the diagnostic criteria for antibody-mediated rejection, biopsies are stratified based on what the histology shows and what the immunopathology shows, and changes of both histology and immunopathology merit a diagnosis of antibody-mediated rejection. So what I want to focus on for this talk is the challenges of antibody-mediated rejection. First, prevention. How do we identify patients at high risk for AMR? Can these high-risk patients be treated prior to transplant? Can we do things to prevent this patient from presenting in cardiogenic shock 4 months post-transplant? And then treatment. Once they do present, how should AMR be treated? And if the initial therapy fails, what do we do next? So let's begin then with basic transplant immunology, or immunology that a cardiologist like me can understand. So there's two forms of acute rejection. There's cellular rejection. CD4 and CD8 T cells target the donor human leukocyte antigens, HLA, which lead to cytotoxic T cells and cell damage. Then there's antibody-mediated rejection, where B cells activate two plasma cells, which in turn form antibodies against HLA, which lead to complement-dependent cytotoxicity. So this is an important set of things: B cells, plasma cells, antibodies, and complement. We're going to remember those factors because they weigh very heavily into how we target the process in the prevention and treatment of antibody-mediated rejection. So when we think about prevention of antibody-mediated rejection, we have to know the targets of the immune response, which are these human leukocyte antigens, which are present on the surface of all nucleated cells. That's class 1. Class 2 on antigen-presenting cells. And the risk factors for sensitization are those conditions whereby someone is exposed to foreign HLA. So how does that happen? That happens through blood transfusions, because some nucleated cells sneak in, pregnancy, previous transplant, mechanical circulatory support. And the goal is to identify these sensitized patients prior to transplant. And the way we do that is by checking for anti-HLA antibodies, also known as panel reactive antibodies. Now, panel reactive antibodies, or PRA, is a historical term, because back in the olden days, they would take a panel of volunteers' cells, mix recipient serum with that panel of cells, and see what lit up. Nowadays, they're synonymous, but that's more historical. There's also non-HLA antibodies, which are more experimental and which I won't focus on for now. So the first step, if you're looking for anti-HLA antibodies, is, are they there or not? Screening. And while this is the most inexact, gross, non-specific estimate, it still has prognostic value. In this classic paper from years ago, patients who had an elevated PRA early pre-transplant had up to a worsening survival up to 5 years post-transplant. So just knowing that your patient is sensitized gives you a sense of their prognosis. But what we care about is not really that they're there. We want to know what they are. And knowing what they are relies on the technology of the fluorescent bead assays. So patient serum is passed through a column containing latex beads. Each bead is bound with a specific HLA antigen. Antigen antibody complexes bind, are tagged with a fluorescent carrier, passed through a flow cytometer, whereby the identity of specific anti-HLA antibodies can be determined. But again, we don't just want to know which ones are there. We want to know how important they are. Is this a weak, ineffective antibody that won't do much? Or is this a strong antibody that's likely to be killing in vitro? So in vivo. So our best measure, our best predictor of in vivo cytotoxicity is in one in vitro assay of strength called the mean fluorescent intensity, or MFI. Now, different labs will have different cutoffs, but at Cedars, we use 5,000 and 10,000 as our cutoffs for weak, moderate, and strong. So this is important because it can give you a sense if a patient has antibodies, which ones do I need to take seriously? But there's in fact another way to predict in vivo cytotoxicity, not just by antibody strength, but by antibody function. And to understand the antibody function, we're going to talk about the C1q assay. And to talk about the C1q assay, we have to talk about the complement cascade. Okay, another confession. I love cardiology because it makes sense. I didn't love the complement cascade in medical school because it didn't make a lot of sense to me. But life comes full circle again, and here we are, a cardiologist having to understand the complement cascade. So how does it work? Antigen antibody complexes bind C1q, the first step in the complement cascade, which leads downstream to the formation of the membrane attack complex, cell lysis, and death. So the ability of the anti-HLA antibody to fix complement, bind C1q, is what makes it cytotoxic. If it can't, then the membrane attack complex can't form and bad things can't happen. And identifying C1q positive anti-HLA antibodies refines our ability to predict potential cytotoxicity. And this was shown very elegantly some years ago by Dr. Alex Lupi, a Parisian transplant nephrologist. Of course, it's an elegant study. He's in France, but it's really quite beautiful that he took kidney transplant recipients and he stratified them by the presence or absence of donor-specific antibodies, and then by whether they were C1q positive or not, and found that if these kidney transplant recipients had C1q positive donor-specific antibodies, they had reduced graft survival. Not so for the donor-specific antibodies that were C1q negative. So it is another way to predict how these antibodies will perform in the patient. So how do we put all this information together? We have a pre-transplant protocol for the management of sensitized patients. You check the PRA, measure the identity, the strength, the function of the anti-HLA antibodies. If they're negative, recheck every 6 months or 2 weeks after a sensitizing event. If there are strong binding antibodies, we use this information in 2 ways: to perform a calculated PRA and to decide on a prospective versus virtual crossmatch. So let's start with the calculated PRA. The calculated PRA is actually what matters clinically for patients on the waiting list. It answers the question, how easy will it be to find a donor for my patient awaiting transplant? Because the CPRA defines the frequency of unacceptable HLA in the donor population. So step 1 is to define what you consider unacceptable HLA. So here is a sample panel reactive antibody, anti-HLA antibody report. And you can see that there are multiple antibodies here and their MFIs listed. I've colored in red and blue, everything with an MFI over 5,000. So we say in our lab, 10,000 is definitely cytotoxic. Let's hedge our bets and say we're going to avoid anything over 5,000 just to be safe. The next thing you do is then you want to define the frequency of these HLA in the population. And the way you do that is you go to Google and you type in CPRA calculator, which will take you to this website. And you click, 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 and you hit calculate, and that will give you a number and a nice graphic. And if the number is high, that's bad, because a CPRA of 80% means that only 20% of potential donors would be a match, and your patient is going to have a long wait to transplant. But remember, this all hinges on step 1, defining the unacceptable HLA. Say you were not so risk averse, say your patient was unstable, and you didn't want to avoid everything with an MFI over 5,000. Say you wanted to just avoid those that were C1q positive, and those only happen to be the ones in red. Then you'd go back to your CPRA calculator, and now your CPRA is 32%. So you've gone from 80%, only 1 in 5 donors is a match, to 32%. Now 1 in 3 is a match. Better odds, better chances potentially of finding a donor. So you use C1q, you define your threshold differently, you may get more offers, there's still more potential for rejection as you're predicting the future, and it's all about balancing risk. But the risk of a high calculated PRA is not just theoretical. In this beautiful study, also elegant, done by one of my partners, Dr. Kransdorf, on the UNOS registry, he found that a higher CPRA is absolutely linked to fewer transplants and more deaths. In fact, if your CPRA is above 80% versus less than 10%, longer wait to transplant, 200 days versus 59 days, 70% less likely to ever get a transplant, and 2 times more likely to die or be removed from the waiting list. So a high CPRA is not a good thing for a potential transplant recipient. So we try to do things, therefore, to bring down the CPRA and broaden the donor pool. And that includes desensitization if the CPRA is above 50%. So there's different protocols we can give for desensitization to bring down the PRA. There's a theme that runs through all of these, and that they are essentially all stolen from the kidney transplant literature. So this is the first one we started to use some years ago, adapted from the renal transplantation experience. The components include plasmapheresis for inpatients because it removes preformed antibodies, IVIG to block antibody function, and Rituximab, a monoclonal antibody against CD20 on B cells to cause B cell destruction. So this protocol, the IVIG Rituximab protocol, targets mainly the B cells and the antibodies when we think about our cascade of things that impact AMR. So B cells, antibodies. And in fact, it was shown quite nicely by Stan Jordan, who is one of the transplant nephrologists at Cedars, that it works quite well in kidney transplant candidates. So in his study years ago, they took the CPRA down from 77% down to 44%. And the serum creatinine of patients who made it to kidney transplant was generally preserved up to 1 year post-transplant. But like anything in medicine, once you discover a brand new advance that works beautifully, you will discover the subset of patients in whom it doesn't work. And that's exactly what happened with the IVIG Rituximab protocol. Some patients have an persistently elevated PRA despite IVIG and Rituximab. And this is a sample patient. He was waiting for redo transplant, hence he was highly sensitized. He had 5 troublesome high-level antibodies. You can see her, the green dotted line, it's an MFI of 5,000, and these were all much higher. After the first round of plasmapheresis IVIG Rituximab, things were looking up. But then he had a rebound after the second round of IVIG and Rituximab, and we were very worried because this patient was inotrope dependent in the hospital with a PA catheter and no hope of making it to transplant, until we gave him a brand new therapy, brand new as of 2009, that magically worked to plummet his antibodies and get him safely to redo transplant. And that magical therapy at the time was Bortezomib. So Bortezomib is the next level in our armamentarium for sensitized patients. It's a proteasome inhibitor targeting plasma cells and thus approved for multiple myeloma, a plasma cell dyscrasia. And it's a 2-week inpatient protocol that involves plasmapheresis and Bortezomib. So we said before, the IVIG Ritux targets antibodies and B cells. The plasmapheresis Bortezomib targets antibodies and plasma cells, getting closer to the meat of the problem. Now, we published our early experience with Bortezomib in 7 patients who all had a CPRA 50% or higher despite plasmapheresis, IVIG, and Rituximab. There were side effects, infections, catheter-related C. diff, UTIs. There was neuropathy, self-limited, better with subcutaneous administration. And our outcomes, the CPRA went from 60-something% average down to 35%. 6 of the 7 were successfully transplanted. 1 patient had no benefit and died from sepsis after cycle 2. So the lessons learned from our experience with Bortezomib: first, it is hope for the highly sensitized. These were 6 patients we worried would never survive to transplant, who ultimately did survive and thrived. But there's also the law of diminishing returns, meaning if a cycle doesn't work, by repeating the cycle, you reduce the chance of benefit of reducing antibodies, and you increase the chance of harm, of infection risk. And yes, the theme continues that as we get excited about a new advance and we apply it to everyone who needs it, we again find that subset of patients who are refractory. And in fact, there are some patients with really refractory antibodies. Some patients have a persistently elevated PRA despite IVIG, Rituximab, and Bortezomib. So here's a sample here. The blue dots are the CPRA hovering at 100%. This patient received IVIG Rituximab. The blue dot continues to hover at 100%. She received Carfilzomib, a cousin of Bortezomib. No dice. So what did we do here? So she actually got sicker and needed to come into the hospital to be listed status 3 for transplant. And we gave her some therapies, and her CPRA did not budge. And here she is waiting in the hospital, month 1, month 2, month 3. And all of a sudden, at the start of her 4th month in the hospital, the CPRA magically dropped. And this window opened up. When instead of her CPRA being 100%, now we're in the 70% range. Amazing. At the same time, fortuitously perhaps, she worsened, required a balloon pump, which upgraded her to status 2 listing. So the stars aligned. Her priority for transplant listing went up at the same time her donor pool expanded based on her antibodies. She successfully made it to transplant and was home 10 days later. But it was an incredible odyssey to get her there. And the magical therapy that brought her successfully to transplant was Tocilizumab. So Tocilizumab is the newest agent in our armamentarium against sensitization. It targets IL-6, which promotes inflammatory events, including the expansion and activation of T cells, differentiation of B cells, antibody production, again, allowing us to target this cascade from multiple different angles. And again, we have stolen from the kidney transplant literature, where they have shown, Dr. Jordan, our colleague here at Cedars, that it is very good for desensitization, will reduce the mean immunodominant donor-specific antibody pre, at, and post-transplant, and also can increase graft survival probability in kidney transplant recipients with chronic active AMR. So the protocol involves plasmapheresis IVIG and then Tocilizumab monthly for 6 months. We found in the handful of patients we have given it to thus far, it is very well tolerated, but it will take 3 to 4 months to see a benefit. So there you have it. That is how we take the information from the strong binding antibodies, use it to perform the calculated PRA, and to decide on desensitization. All of these things are things we do in the waiting list phase of transplant. But what do we do when an offer is actually available? That gets to the prospective versus the virtual crossmatch. How do you handle antibodies when the recipient, when the donor is right there in front of you? So there's 2 ways to do the crossmatch, 2 general ways. The virtual crossmatch is done on paper. The purpose is to avoid donors with HLA, to which the recipient has strong anti-HLA antibodies, and prevent the dreaded hyperacute rejection. So hyperacute rejection, when the heart is put in, most commonly referred to in the setting of blood type mismatch, where there's preformed antibodies that attack the heart and kill it on site. To avoid that, which can also happen with anti-HLA antibodies, you can perform a virtual crossmatch. Step 1, define the cytotoxic HLA by MFI threshold or C1Q. Say, I will not accept a donor with these HLA. And then if a donor comes up who has them, you say no. Now, the virtual crossmatch is done purely on paper, so it is purely theoretical. If you use a C1Q cutoff, you might get more donor offers, but you may get possible rejection. It's about balancing risk. Now, the virtual crossmatch is very useful if you have 1 or 2 high-level antibodies, meaning the patient is highly sensitized but narrowly sensitized. What if the patient is broadly sensitized? What if there's multiple moderate-level antibodies? Should you cross them? Should you not cross them? Is crossing 1 okay, but 5 bad? How do you make that prediction? It's very hard to do that on paper. So in that situation, we rely on the real prospective crossmatch, where the goal is the same. You're avoiding donors with HLA to which your recipient has cytotoxic antibodies and prevent hyperacute rejection. But instead of doing it on paper, you're doing it in a test tube. So you test recipient serum against donor cells at the time of an organ offer. Now, there are geographic constraints that limit the donor pool because you can't logistically bank your recipient serum at every organ procurement organization, but you'll do the ones relatively local to you. But that is really what you need to do in the case of broad sensitization, because you can't rely on a paper test to predict the future. So when you do a prospective cross-match, there's two ways to go. Recipient sera containing anti-HLA donor-specific antibodies are mixed with donor lymphocytes, and then one of two things will happen. You will either add complement and see if the cells die. That's a CDC cross-match, not Centers for Disease Control, complement-dependent cytotoxicity. And a CDC cross-match tells you antibodies are present and they can kill. A positive CDC cross-match is basically hyperacute rejection in a test tube. The second way to do a prospective cross-match is to take recipient serum, donor cells, and then add fluorescent conjugated anti-human globulin. And then pass it to a flow cytometer. So it's a flow cross-match. So it's basically telling you antibodies are there, but I'm not sure about their killing potential. So obviously a CDC cross-match is a horrible warning. And if you have that, you stay away and you say, thank goodness my patient dodged a bullet. I know something bad would have happened if they transplanted this heart. I don't want that heart. If there's a flow cross-match, is that bad? Clearly it's more sensitive, but is it actually specific for hyperacute rejection? So there are some studies to offer insight into this. One from 20 years ago is shown in the figure on the left, where you can see that if you have a positive flow cross-match, there was decreased survival. But a lot of advances have transpired in the last 2 decades. And in this study a decade ago, where patients were transplanted with a positive cross-match, but given IVIG, Rituximab, plasmapheresis, there was no increase in death, but there was increased rejection. So how do you manage the cross-match? Well, if you're flow negative, CDC negative, you crack open a bottle of champagne and you proceed with the transplant. If you're CDC positive, well, the definition of insanity is doing the same thing over and over again and expecting a different result. So if you've already had hyperacute rejection in the test tube, you will not test that out in vivo, you will decline the heart. But what if it's flow positive CDC negative? Now, some centers will do ATG, plasmapheresis, IVIG, Rituximab, multimodal kitchen sink to reduce the problem from these antibodies. Now, at Cedars, we do transplant patients with a flow positive cross-match. We have done so with our new secret weapon safety net of Eculizumab. So let's talk about Eculizumab. And here it is, twice in one presentation, the complement cascade. So Eculizumab is a humanized monoclonal antibody that binds to and prevents activation of complement component C5. You may have heard of it for paroxysmal nocturnal hemoglobinuria or atypical hemolytic uremic syndrome. So the way it works, as we talked about, remember, the antigen antibody complexes bind C1q, downstream form the membrane attack complex, which kills the cell. Eculizumab acts at the terminal component of the complement cascade right before the membrane attack complex. So basically, Eculizumab cuts the complement cascade off at its knees. You have very scary antibodies. They can bind their antigens, but they can't do anything. It's like an assassin with a gun with no bullets. And that is what Eculizumab is for patients at risk for AMR. We actually recently completed the DUET cardiac study, a study at Cedars, open label pilot of Eculizumab in 20 highly sensitized patients. All of the patients had a positive flow cross-match and at least one donor-specific antibody at the time of transplant. And how it works is Eculizumab was given at the release of aortic cross clamp in the operating room and then weekly for 7 weeks. Now I know what you're thinking. What's up with this? She presents us studies with 7 patients, 10 patients, 20 patients. Listen, it's heart transplant, right? It's not atherosclerotic cardiovascular disease. Our numbers are small, but I hope that you'll find these results as compelling as I do. So at 1 year, 1 year survival of 90%, the 2 patients who passed away actually passed away of sepsis, multi-system organ failure, not rejection. All of the patients had donor-specific antibodies at 1 month, of course, because they came in with donor-specific antibodies. No cellular rejection. only 20% had treated AMR, none with a reduction in EF at the cost of some infections. This is actually pretty extraordinary because these 20 patients were all referred to us, some locally, some from around the country, so highly sensitized that they had no other options, living on borrowed time. And to get their 1-year survival comparable to the national average really to us was amazing, amazing for them. But then I guess the next question you're asking is, well, maybe they would have done just as well without the Eculizumab. Maybe we've gotten so good in this day and age with everything else you throw at them. So where's the control group? So we thought about that, and we went through our patients to look for a historical control group, patients with a positive low PRA who went through transplant without Eculizumab. And in fact, we couldn't find any patients because before Eculizumab, we were too chicken to transplant against a positive flow crossmatch. So we went to our colleagues in France, the Paris transplant group, and they were kind enough to loan us data on 20 patients with a positive flow crossmatch who received plasmapheresis and IVIG, but no Eculizumab. And lo and behold, the incidence of biopsy-proven AMR was far lower in our patients, as was the number of biopsy-proven AMR per patient. Eculizumab has been our secret weapon for these highly sensitized patients. So that has taken us through the prevention of antibody-mediated rejection. Now let's talk about treatment. How should AMR be treated? And if the initial therapy fails, what do we do next? So back to the case. We have a 35-year-old woman, 4 months post-transplant, nausea, vomiting, fatigue, EF 20%, cardiogenic shock, VT, balloon pump, dopamine, dobutamine, biopsy with AMR. Treatment is continued with methylprednisolone for 3 days, followed by a prednisone taper, ATG, plasmapheresis, followed by IVIG. Over the next week, the balloon pump is removed, heparin is stopped, inotropes weaned, the catheter comes out, and the EF increases from 20 to 40%. So congratulations, her life has been saved. What do you do now? Well, you could list her urgently for retransplantation, change immunosuppression, repeat the biopsy, initiate Coumadin. Well, Coumadin's not the right answer. You will give IV heparin in the throes of acute rejection, but in the absence of atrial fibrillation or thromboembolic disease, there's no indication for long-term anticoagulation. You're not going to list her urgently for retransplant for 2 reasons. First, it's not clear she's sick enough to need a second transplant. And second, as case series demonstrate, when you transplant patients within the acute phase of an acute rejection episode, they do very poorly. Whether it's the activation, the milieu of the immune system that then just rejects the new heart, it's not a good idea. But we will certainly repeat the biopsies per protocol and alter her immunosuppression to include a proliferation signal inhibitor, sirolimus or everolimus. You've heard of all these, of course, because of drug-eluting stents. They inhibit the proliferation of T cells, B cells, smooth muscle cells, and endothelial cells. By doing so, they prevent in-stent restenosis and also rejection. In clinical trials, less rejection, less allograft vasculopathy, fewer viral infections, particularly CMV, at the cost of worsening renal insufficiency and some impaired wound healing. So we reserve it for patients who have a specific indication, such as rejection. So her MMF is stopped, sirolimus is started. In clinic 1 week after discharge, her dyspnea on exertion is improved. Heart rate 120, blood pressure 110/80, EF 45%, RA 15, PA 30/20, wedge 20, index 1.8. Biopsy shows no cellular or antibody-mediated rejection, but she has a new donor-specific antibody to DQ7 with an MFI of 8,000 that is C1q positive. So you're happy because she feels better, her EF's okay, and she has no rejection, but you're sad because she's tachycardic with elevated filling pressures, a reduced cardiac index, and a new donor-specific antibody. And this is all too commonly the sequela of antibody-mediated rejection, where there's this smoldering phase of partial recovery. So what should we do? Should we ignore that PRA because she had IVIG? Should we repeat the biopsies per protocol, start photopheresis, administer IVIG and Rituximab? Well, we'd like to ignore the PRA, as we always like to ignore any test result that doesn't fit the picture we want it to fit, but we can't because the IVIG was a few weeks prior, so will no longer be affecting the PRA. And we're certainly going to repeat the biopsies, and we'll talk a bit about the role of photopheresis. But first, PRA. So there are studies spanning decades to show us that patients with donor-specific antibodies do worse, more rejection, decreased survival. And when we think about the treatment of rejection, I showed you this earlier, we actually do alter it in the presence of donor-specific antibodies, where we'll be more aggressive with our treatment of AMR if patients have donor-specific antibodies. What about photopheresis? Well, it's a little known fact that the ancient Egyptians, in fact, practiced photopheresis. When patients had, they observed that when people had vitiligo, which is a T-cell mediated autoimmune process against melanocytes causing patches of depigmentation, when they ate the leaves of a certain plant, their vitiligo got better. Well, that plant contained sorolin, which intercalates into the DNA of rapidly dividing cells that when exposed to UV light causes the cells to die. So the procedure, a bit more high-tech now in the 21st century, involves the principle of immunomodulation to promote the destruction of cytotoxic T cells. It involves leukophoresis, remove white cells, photoactivation, mix them with sorolin exposed to UV light, causes apoptosis, and then reinfuse. Now, it only affects a small proportion of the circulating T cell population, but for mysterious reasons causes global immunomodulation. It's been tested in primary prevention and recurrent rejection, and has been shown to cause a reduction in rejection as well as coronary intimal medial thickness. So when we think about our AMR maintenance protocol, 2 weeks after the treatment for rejection, we'll check an echo, a biopsy, right heart cath, anti-HLA antibodies. If the patient has a normal ejection fraction and normal hemodynamics and no donor-specific antibodies and no rejection on biopsy, we'll tell them to not bother to buy a lottery ticket because they've already won the jackpot and escaped the sequela of antibody-mediated rejection, at least for now. If, however, as is more common, they have persistently reduced ejection fraction or abnormal hemodynamics or donor-specific antibodies or persistent antibody-mediated rejection, we'll give them something. We'll consider IVIG, Rituximab, Bortezomib, Tocilizumab, photopheresis. Are we treating them? Are we treating ourselves? Does any of this work? No one quite knows at this point. For this particular patient, due to persistent restrictive physiology and donor-specific antibodies, she receives photopheresis for 6 months. She has fluid retention, which can be a side effect of sirolimus, though also a side effect of a restrictive cardiomyopathy, and MMF is restarted. The DQ7 donor-specific antibody persists, and her first annual coronary angiogram demonstrates mild luminal irregularities. Now, you might say, if you're a glass half full person, well, the angiographer was just having a bad day. I'm sure the angiogram is totally fine. Or if you're a glass half empty or a realist, as I like to say, you might think that this is happening. So a picture is worth 1,000 words. This is a representative sample of what happens to patients with early AMR. Year 0, the donor coronary angiogram. Look how beautiful, plump, healthy arteries. Year 1, it's a little harder to see them. Year 2, it's as if they've been obliterated. And that is the classic findings of cardiac allograft vasculopathy, this diffuse process of pruning, of fibrointimal proliferation that affects not only the epicardial coronaries, but the microvasculature as well, leading to global ischemia, reduced DF, stiff heart, and high risk for death. Antibody-mediated rejection is a strong risk factor for allograft vasculopathy, as if the endothelial injury that happens at the time of AMR starts this process going. So in this patient, 2 years post-transplant, she has diffuse cardiac allograft vasculopathy. Her EF is 35%. She has no AMR, so her low EF is not from rejection, it's from CAV. She's listed for redo transplant with progressive hemodynamic compromise requiring status 1A listing. In this system would be status 3. Her CPRA is 30%. It's not high. She doesn't have a ton of antibodies. It's just the ones she has are bad for the heart she has. She doesn't require desensitization. She's listed with a virtual crossmatch. After transplant, ATG induction, standard immunosuppression, switch to sirolimus at 6 months with a standard biopsy and PRA protocol. So in a way, this is a happy ending of this odyssey that began in the emergency department 2 years earlier. But in a way, it's a tragedy that her new heart sent her along the spiral that ended up here. So today, we've talked about the challenges of antibody-mediated rejection, including prevention and treatment. We've talked about assays for the identity and function of HLA antibodies, how we use that information to do a CPRA and a crossmatch, and decide on desensitization strategies targeting B cells, plasma cells, antibodies, and treatment with long-term therapy, including photopheresis and desensitization. Well, I'd like to thank all of you for your attention, and I'm happy to take any questions.
Dr. Kittleson, thank you so much for that excellent talk. We have quite a number of questions that are coming in on the chat. Dr. Bellum Conde, can I have you on mute and just ask your questions directly? I think it'll be more helpful that way.
Hi, Michelle.
Hi there. Nice to see your name on my screen. Hello.
Welcome back. It's so nice to have you. As always, such a wonderful talk. A couple of quick questions. So you mentioned Toci and Bortezomib. Are you using this routinely in all refractory patients with a PRA of 50% and above, or are you using them only in highly sensitized patients with a PRA of 80% and above? So I'll let you answer that, and then I have a follow-up question.
That's a great question. You know, back when we did those initial studies with plasmapheresis and Bortezomib with IVIG and Ritux, 50% had been our cutoff. In fact, now that we are a bit better, I think, at defining the unacceptable antibodies to calculate the CPRA, you're right, we tend to go higher at 70 or 80%, but it sort of depends in a sense. If you have a patient whose CPRA is 50%, but they're 6'4" and blood type O, maybe I still want to try to get that as low as possible. If I have someone with a CPRA of 60%, if they're 5'2" and blood type AB, maybe I'll be a little bit more lenient. And so you factor into account what their global wait time is going to be based on their CPRA and also other that might affect wait time.
Okay, so yeah, that makes sense. Thank you. Now, just a follow-up question to that, again, as you alluded to, the global wait times are different in different regions. And with the new allocation system, it's, again, it's kind of reducing overall, especially for the higher status patients. Now, what's your take on patients who are sensitized and highly sensitized, especially, excuse me, regarding taking a marginal donor with a little LVH or maybe using DCD HOTS or HCV HOTS, mild coronary artery disease, rather than desensitization, and then kind of what you've alluded to in your talk with the risk of rebound after a few months of rebound antibodies?
Yeah, oh, that's such a good question. You know, I think HCV hearts I would take with a clean conscience. I don't think we have any data yet compelling, and I don't believe we will, that it's going to be so awful long term. And you might say, but wait, you're taking a sensitized patient and you're going to slam them with stuff and then they got HIV. But I guess I believe so strongly in the power of these acting antivirals that I think HCV would be all right. Now you're talking about DCD donors. We are not using the donation after circulatory death yet. I think that would be a learning curve where you're right. We wouldn't want to take someone who's also already tenuous and added unknown to the equation. When it comes to a marginal donor, a little bit older, a little bit of LVH, a little bit of CAV, I think the answer is yes, no, maybe so. It so much depends on, do we have a highly sensitized status 1 on ECMO of all, or is it a status 4 LVAD who's smooth sailing? So I think it could factor in that situation.
Okay, thank you so much.
Of course.
Dr. Kittleson, we have a few additional questions coming in on the chat. From Aria Mani, he asks, is there any trial of antisense oligo against complement factors?
The short answer is I'll say I'm not aware of any, but as we all know, whenever a resident says I'm not aware, it doesn't mean that's not really true. So I'm not sure. That sounds really fascinating though, and something I'm going to put on my list to look up when this talk is over.
Great. So more questions here, and you can probably see some of them in the chat as well, from Dr. Bender, and he's asking if low PRA is a risk for CAV, and also what about anti-endothelial cell antibodies?
So,
Michelle, this is Jeff Bender. Sorry to interrupt. I just wanted to explain that first part, the first question.
Sure.
So with low PRA, you would be likely to transplant somebody, but low and present PRA, you had said that antibodies are a risk for allograft vasculopathy. I mean, I think that for many years that was debated, but it's probably less debated now. So I just wondered if you had any kind of aggressive protocol or longer term assessment of whether that's actually a risk for allograft vasculopathy.
you know, it's really interesting. So if there's a low PRA that we tend to ignore or don't pay attention to, and then does it get worse post-transplant and ultimately lead to worse allograft vasculopathy long-term? That's really interesting. I don't know any data of that, but you know, we check PRAs every 6 months for life, and you often have these people who are 10 years out, and all of a sudden they've got this donor-specific antibody that's now, it was an MFI of 2,000, blah, blah, blah. We weren't thinking about it. And all of a sudden, 10 years out, now the MFI is more like 10,000, or now it's C1q positive, and now their angiogram is a minor vasculopathy. That's very interesting. Do we poo-poo the low levels to the patient's detriment, and is there some risk long-term of them smoldering? I think that's really fascinating. I'm not aware of any data for that, but it definitely makes sense clinically. I think your second question was about the anti-endothelial cell antibodies. So, you know, the non-HLA antibodies, I think they're the elephant in the room, in the sense that you have someone with antibody-mediated rejection or biopsy-negative rejection. You've got a low EF and you can't figure out why. The donor-specific antibodies, there are none. But then you check for Vimentin or the anti-endothelial or MIC-A, and all of a sudden there's something, or AT1R, and there's something there. And I think we need to more routinely check those, to be honest, because I think we might miss some setups, risk patients for future AMR and CAV down the line by not paying attention to those antibodies. But so much here is, you know, just because you know about it, what are you supposed to do about it? That becomes often a challenge, but your point's well taken.
Thank you.
Thanks a lot. And Dr. Velasquez?
Hi, Michelle. Thank you again for joining us. And it's great to see my colleagues from Bridgeport also joining in support. I have a question that's really more kind of system-based. First, I wanted to ask you to say hi to Evan Kransdorf. So it's been a long time since I heard his name, and I hope he's doing well. He was one of my first residents in clinic.
How awesome. Yes, he's amazing. I will.
So my question to you is, you know, transplant care defines a team sport in medicine. Can you speak to us and just give us your perspective on you know, how your organization has integrated all this expertise around dealing with you know, the pre-exposure and the PRA risk, and how you make this happen? What in your perspective, what defines the components of the successful team when you're pursuing a desensitization and managing these very complex patients with high PRAs?
Yeah, it's exactly right, because in medicine in general, no one can know everything, and in transplant in particular, that's no more true. So the components for success, it's not just, you know, a transplant cardiologist willing to evaluate the patient. Yes, you're sick enough, here are your antibodies. You need to have that cooperation with the immunogeneticist, the immunogenetics lab. Yes, I'll run that assay. This is what this assay means. Let's troubleshoot. Let's try MFI this or C1q that or anti-endothelial cell, or let's do a surrogate cross-match to figure out what might happen. So all kinds of new novel techniques. I think in general, it's also helpful to have a strong kidney transplant program, since we steal so much of what we do. They do it first, and then we tag along and try it in our patients. And the other part of it is you need to have surgeons that are willing to take on a lot of risk, right? You know, God bless them for cracking people's chests open with the chance that there can be delayed hyperacute rejection, the chance that the 30-day outcomes might be a little rocky as you're learning something new. And in addition, you need to have the buy-in of administration at large. You know, Eculizumab costs 30 grand a dose, and yes, there are studies for it, and yes, there's compassionate use, and you can try to get the insurance company, but I think you have to have an administration also that's committed to the process. And because these patients may very well have a more rocky course after transplant, you need to have the cardiac surgery ICU team, as well as the pharmacist, and the infectious disease specialist, and the physical therapist, you know, all working together, because this is a higher risk cohort of patients, higher stakes, higher morbidity coming out of the operating room.
Thank you. That's very wise, you know, as we look at increasing our volume here, and maybe a learning from your you know, what you've educated us here today, I think we'll take those recommendations to heart.
Thank you.
Dr. Kittleson, I think we have just time for one final question, and this is from John Stendhal, just asking you to explain the mechanism for which MCS affects the risk of rejection, and asking if it's the exposure to foreign material or simply associated exposure to blood products.
Yes. I mean, you're exactly right. It's absolutely both. And it's sort of hard to tease out in a way, since patients with MCS by nature get so many blood products, but it's absolutely a combination of the two factors. I mean, it's not like an aortic homograft, for example, in a congenital patient, which is such a nidus for sensitization, but there absolutely is something about the device and something about the blood products that are needed for the device together that cause sensitization in patients with mechanical support.
And I think that is all the questions that we have. And I just want to thank you again, you know, for such a fantastic grand rounds. And we'll see everyone back again next week. Thank you again, Dr. Kittleson.
Thank you so much. It was great. Thank you so much.